Morning, everyone. A real pleasure to see you all bright and early here. Very pleased. I think we're 8:30, but I can see a couple of people walking in, so we'll give maybe 30 seconds or a minute more for people to walk in by the time. But let me all just, first of all, wish you a good morning and welcome you to this pre-Congress course. The whole idea behind this by Andres and me was that how can we put all about one anastomosis bypass and SADI, so loop gastric bypasses, and make the most of it in a day. So learn from the basics to tips and tricks to the mistakes we have made so that somebody who wants to start, don't make that mistake and repeat it. You make your own ones and then share it with us. And that's the whole idea. And we'll try and divide it with the whole OAGB and SADI, and we have tried to put it all together so it seemed like a seamless discussion. And we want this course, as you can imagine, to be more interactive as well. So please ask your questions, anything you feel like, so that we can have a nice, healthy discussion by the end of the talk. And over to Andres.
Thank you, Chitan. Well, I think it's going to be a quite interesting course because I consider this to be the two most perhaps growing, although they are a bit old, surgeries. And another thing that could be our aim today is to demonstrate that these operations are more physiologic than those that are appearing today as SASI or bipartition. I mean, these have more sense, and so we have to demonstrate it today.
Yeah. I think
we can start when you want. We have Jack at the first.
Yes, Jack is not here. Maybe we can just start with Fritz. Fritz is here, so we'll start with
Fritz.
Fritz,
yes.
You want to call him?
Okay. As Dr. Hempens, I don't see him today. We will start with Dr. Burns from the Netherlands, that will speak us about the many effects of these one anastomosis surgeries. Fritz, welcome to Spain. Nice to see you again.
Thank you very much.
And before he starts, the speaker room is upstairs, so if you have to upload your talk, it's just near the registration desk. They do take very rarely laptops if you really can't do that, but I think it's a faff apparently, I'm told. So please upload your talks up in the speaker room. Thank you.
This is not the right. You have to have the second one, Berends. Berends, Fritz.
Fritz.
Fritz. You, Fritz.
Yeah.
Thank you. That's it. Quite an honor to be here in such a distinguished company. I'm going to talk to you about the many effects of one anastomosis gastric bypass. And in hearing that, you probably guess that this is going to be a really simple talk because the main effect of OAGB is significant weight loss. And having said that, I'm almost done. But I assume in getting this title, what was meant was that I discuss with you the effects behind the scenes that lead to this weight loss. I'm a Dutch surgeon. I own a private clinic together with Edo Arts. You probably know him, doing more than 2,000 procedures a year, 75% of which is OAGB. So I have some experience in doing OAGBs. But not always. I started doing this only 5 years ago. Before that, I was a little bit skeptical about that. And maybe that's my main disclosure. Because throughout my career, I've always been looking for that procedure that would give me the least frustration, no complications, and best weight loss in the long run. And although OAGB is not a perfect operation, maybe it brings me closest to preventing these frustrations. Now, having said that, you probably realize that an OAGB is much more than just a smaller stomach and a bypass. It goes into, of course, different anatomy, but it's also about gut hormones, about bile acids that trigger receptors in your small intestine, about your microbiome. I didn't realize before that even your colon plays a role in losing weight. And finally, in brain mechanisms. Going into the anatomy, not to go too deep into this, because there's going to be following speakers that discuss this with you in detail, but I find it's very essential to make a long, narrow pouch, which was originally designed by Rutledge, as you probably know, to prevent reflux of bile into the esophagus. But it turns out that it also helps in slower gastric emptying, which is essential in losing weight. That's the reason that we tell our patients not to drink and eat at the same time, because if you eat something and you swallow it away with liquids, then you don't get that sense of fullness that's necessary to reach satiety. So a long, narrow pouch and a small stoma helps in doing that. And the other key thing is to have a long biliopancreatic limb that helps you to achieve all these other mechanisms that we're going to talk about. I think there's going to be another talk about limb length. Comparing OAGB to Roux-en-Y in many studies, most important of which is probably the OMEGA trial. You're probably familiar with it. It shows that OAGB does maybe even better in terms of weight loss, especially in the first years. After 5 years or so, there's not a lot of difference anymore. It reaches the same resolution of comorbidities, but there's also some downsides that I'm not going to go into, but that are going to be discussed later on. Now, to be fair about all these RCTs, even the OMEGA trial, which is a very outstanding trial, when you compare OAGB to Roux-en-Y, you should be comparing the same configuration, the same anatomy. But what we often do is, when we do in Roux-en-Y, we make short pouches, we make short limbs, whereas in reality, you should be doing roughly the same configuration as you're doing in OAGB. So a long pouch, which also helps you in surgical terms, which makes revisions easier, and also make a long BP limb, which is something about Roux-en-Y I'm saying for years. So in my clinic, in the 25% of cases where I do Roux-en-Y because of reasons of reflux, I always make also in a Roux-en-Y a long pouch and a long BP limb. And then you have a fair comparison, because what you're striving for is this hindgut effect. Because you must realize that if you make this end of your BP limb longer, then the food that you're ingesting, or your patients are ingesting, lands in the connecting part. And the more distal it gets, the more upregulation you get from those important L cells that increase in numbers more distally in your whole alimentary tract. So they're the highest in numbers in your colon. Unfortunately, it's not very practical to make a bypass on your colon. Otherwise, we would probably be doing that. On the contrary, the K cells that produce your GIP, they decrease in numbers going down. So I'm not going to explain to you the incretin effect that you probably know, especially when you're also treating your patients with GLP-1 analogs. Then probably you know that all these incretins will give you the same thing: higher insulin sensitivity, slower gastric emptying, better, lower inflammation, etc. Focusing on bile, I always find this part a little bit difficult, but it's basically two things. Bile does two things for you. You must realize that in doing Roux-en-Y, but especially in OAGB bypass, you're delivering a high concentration and high flux of bile more distally in your small intestine. And that does two things. It triggers your L cells that are high in numbers in your terminal ileum, and it leads to a more absorption of bile acids. And those bile acids, they trigger two important receptors that I go into here. I always have difficult pronouncing that, so I'm not even going to try, but the FXR, okay, I tried. The FXR receptor, it's called the storage receptor. What it does is it triggers the production of fibroblast growth factor, FGF, and that in itself regulates storage of the bad stuff in your liver, lipids, glucose. If you have high FGF, you have less storage of the bad things that lead to obesity. On the other hand, and that's the other receptor, the TGR5, is called the burn receptor. It's spread throughout your body, in muscle, in brown adipose tissue, in immune cells, and it leads to a higher energy expenditure and more thermogenesis, a higher output of your T4 thyroid hormones. So the combination of storing less and burning more leads to weight loss, and that's what your bile acids do for your patients. Moving on to the microbiome. For years I have believed that your colon, the main function of your colon is regulating the consistency of your stools. But it does so much more. You're probably familiar with the experiments where they transplant stools from thin patients to obese patients, and those patients lose weight. So the whole microbiome does far more than just correcting the consistency of your stool. It breaks down fatty acids. It makes free calories out of complicated carbohydrates. And in changing the composition of your microbiome helps in losing weight. To what measure is not very well known. The alpha diversity simply means more bacteria, more different bacteria in your stool. More different bacteria elevates the chance of having the right bacteria there. Certain bacteria, the proteobacteria, they tend to break down complex carbohydrates and there elevate your calorie uptake. No, it's the other way around. So they break down your uptake, they inhibit your calorie uptake. And then there are certain difficult other bacteria that I've never heard about where the distribution is important. Now, what mechanisms from an OAGB lead to this change in microbiome? As said, they're not very well known, but it has to do with changed pH, which is an important factor in OAGB compared to Roux-en-Y. You must realize that although bile acid is called acid, it has a little bit lower pH. In doing an OAGB, the pH of your whole chyme, the mix of bile acids and food, is much higher than in Roux-en-Y gastric bypass. And the bacteria in your colon, they experience that. And that leads to a shift in microbiome. There's faster transit, so there's different food and composites of food reaching down in your terminal ileum and your colon, which gives different fermentation. Same goes for selection pressure on certain bacteria that thrive in a bile acid environment, so to speak. And then there's indications that in doing OAGB, there's a little elevation in O2 content, although the majority of bacteria in your colon obviously is anaerobic, but a slight elevation in aerobic bacteria leads to weight loss. Finally, and very difficult to understand is the influence on your brain, which goes in separate layers. Some of these mechanisms are very fast, as you're probably aware. So the pressure receptors in your pouch, they register it when it's full. So that's the very fast influence on your brain through vagal influence. The other one is intermediate fast, the hypothalamus through the POMC cascade. A very difficult subject that deserves a talk on itself, and which I will not go into. What's interesting about this pathway is that it sort of resets the leptin sensitivity, something that's lost in obesity, you know, the signaling from your fatty tissue, from your patient's fatty tissue to your brain, but that's sort of restored within weeks. And then finally, there's a change on a higher level in food choice and food preference, as you probably recognize in your own patients. So putting it all together, all these 5 mechanisms, they contribute to sustained weight loss in the long run, more resolution of comorbidities, and metabolic improvement. The evidence on all this is still not very solid, and there are a lot of questions that I'm sure we're going to discuss in the next talks, one of which is the optimal length in OAGB in humans. For most surgeons, it's somewhere between 150 and 2 meters, but going over 2 meters, you're also bound to have some nutritional deficiency problems. Obviously, there is a separate talk about the long-term and cancer signaling. We don't know a lot about something that's coming towards us, the combination of GLP-1 receptor analogs and OAGB and microbiome I already mentioned to you. It's very interesting, but we hardly know anything about how to treat that. So 5 things you can take home to your Monday clinic. OAGB is not only a surgical, old-school restriction malabsorption procedure, it's endocrine surgery first. It's very similar in terms of weight loss to a Roux-en-Y gastric bypass, but speaking as a surgeon, it's so much easier to do even in your very heavy patients. And in our profession, easier is always safer and thus better. The bile acids are important. They act through L cells and through receptors. The microbiome shift is important, but we don't know how to handle that. And I'm not a very big fan, I don't know how to say this nicely, not a big fan of sleeves. But any procedure is better than none, as long as you stay safe with it. That's probably the most important advice I can give you. Thank you very much.
Any question from the audience?
Yes, Carl?
Thank you, Fritz, for a very nice presentation, very interesting. I'm wondering about this problem of our patients in the long run with a meteorism, with a lot of gas in the abdomen, often causing also pain. And so is it just a consequence of altered fermentation, or I never understood very well? Perhaps you can give a comment on that.
To be totally honest, I don't know, Carl, but you're right. We experience, and you can see that in X-ray swallows, that some of our patients have to have what we call childish swallowing mechanism, where they swallow a lot of air. And it surely is a problem in both Roux-en-Y and OAGB bypasses, because it gives them a lot of pain. It's often mistaken for dumping, which it is not, because if you make, you can see it on an X-ray. What I do find in doing OAGB, so many OAGBs, is that in all our bypass patients, a certain percentage, roughly around 25, maybe 30%, has chronic abdominal pain complaints. But I see that number decreasing in OAGBs. I often hear Thorsten Olber speaking about the outlet problem. He has this theory about that your JJ has something to do with these chronic pain complaints. And obviously, in OAGB, you don't have this JJ. And that's not science, but that's personal observation. I have a strong feeling that OAGB has far less chronic pain.
You have the same impression. Do you have any miraculous treatment for this kind of complaints of the patients?
No, we send them to the logopedist. I don't know the English word. You know, we try to learn them to swallow differently.
Probiotics or so, does it change anything, giving probiotics?
Couldn't say.
Okay, thank you very much.
Thank you, Carl Peter.
My name is Piotr Myśliwiec. I come from Poland. Congratulations, perfect lecture. I'm interested in 25% you do not offer OAGB. Why?
Well, it's simple. One of the downsides of OAGB is the chance of biliary reflux and marginal ulcers, which is smaller in our practice than what I read in literature, but still it's there, and it can be very inconvenient. So in those patients that have very obvious reflux symptoms before surgery, we rather choose a Roux-en-Y, and that's the 25% roughly.
So in esophagitis, you would still offer OAGB in some patients without clinical signs?
We don't do routine gastroscopy, so I wouldn't know. I just listen to their story. What is a lot of reflux before surgery? That's patient. So all of our patients have some kind of reflux. I have reflux if I don't eat right. But what's a lot of reflux? So using PPYs, when you lay flat, it comes up during the night. If you tie your shoelaces, then you leave it. So those are the patients that we qualify as severe reflux patients, and those we give in Roux-en-Y.
What percentage of your patients needs conversion to Roux-en-Y?
It's roughly around 2%. So many of these patients have some complaints even after having lost a lot of weight, 30, 40 kilograms. If they then still have complaints of severe biliary reflux, we convert to Roux-en-Y, which is a very easy procedure. In our hands, it takes 15 to 20 minutes. But obviously, it's not something you're aiming for.
And the last question is about marginal ulcer. My friends from North Poland, from Gdańsk, reported 3% of perforated marginal ulcer after OAGB with long-term follow-up. Maybe it's about the technique you do your anastomosis, because I believe there might be some ischemia in some cases in the distal gastric pouch. What's your comment about that?
Well, I agree with you that it has probably to do with the technique that you're using. Nevertheless, we all see them, but not in those high percentages. And to be fair, I also see them in Roux-en-Ys.
Thank you.
Hello, I'm Jonas Nekvin from Norway. I was wondering, having done so many OAGBs, we started doing a lot in 2015, and then our interest waned because we thought it was a good reflux procedure. It turned out it was terrible, so we started doing a lot of RYGBs instead. But now we're slowly shifting back to OAGBs. But my question is, have you reversed OAGBs back to normal anatomy, and in that case, how would you do it?
You know, that's not the subject of this talk, but that's one of the main advantages of OAGB, especially in talking about doing bariatric surgery in young women, because a certain percentage of our younger women, they tend to have maybe psychological influenced passage problems. And in those patients, if nothing else helps, I convert back, which is a very easy procedure. You just staple off the small intestine that drops down, and then you connect with a linear staple line the two parts, your long pouch with your remnant stomach. And so a conversion and an undo, so to speak, takes about 30 minutes. And it's the perfect solution for those patients that you have no other solution for, especially young women.
And roughly how many of those have you done?
We do about 5 a year, which, well, you have to, what is that, 2 pro mil? But the threshold of doing an undo is low in our case. If after 1 year of trying everything, nothing helps, then I simply offer a reversal. And it's not something, some surgeons tend to fear doing that operation. It's very easy. So And it's a perfect solution. And it's one of the main reasons that I'm not so much fond of sleeves, especially in young people. Because there's no reversal.
Yeah, to be honest, I agree for the reversal part. In my vast experience of one patient of reversal, it has been easy. So, and again, it's not many needs.
And to be honest, those reversals don't solve all the problems, because the problems are most of the time not surgical, to put it mildly.
Yeah. Okay.
Yeah, thank you.
Thank you very much.
Thank you very much for the excellent talk and discussion. We now have the pleasure of having Jack Himpens. I think Jack needs no introduction.
Good morning. I see lots of faces that I know. I apologize for my general situation, but I had a few issues, surgeries, accidents, you name it. So therefore, it might be a little bit more difficult than usual. Now, I was asked to first discuss the technical evolution in bariatric surgery in terms of OAGB. Now, I have to tell you a story. There was in 1997, I met a surgeon who said that he was doing a new type of surgery. That was a simplification of the Roux-en-Y gastric bypass. Maybe you have heard her name. It was Rutledge. And so he said, what do you think of the concept? And I very candidly said, listen, it's simple. If you perform OAGB, I think the only place where you belong to be is in jail. And that was because in those days, there was a famous cancer issue that people talked about because of the bowel reflux into the esophagus especially. So he did not end up in jail, and he ended up dying, unfortunately, poor man. But okay, technical evolution in bariatric surgery. I hope this works. Nope. Yeah. Okay. So when we look at we go back to 1997, okay? When we look at the classic laparoscopic metabolic bariatric surgery, we basically talked about the Roux-en-Y gastric bypass, and this is the post-Mason era. We talked about more complicated procedures like the duodenal switch and its simplified versions, meaning by that SADI. And then, of course, the already mentioned gastric sleeve. And the goal of that new type of procedures was that we wanted to avoid the inherent risks of classic laparoscopic surgery. Why? Because it allowed us to avoid multiple anastomosis, and one anastomosis means one complication. 10 anastomosis means 10 complications possible. And of course, and I think to me that is one of the biggest issues, it's the internal, the risk for internal hernia. And I would like to tell you a little story again. There was a patient when I was a few years ago. I was the chief of the department, and there was a resident who was called to the ER, and because there was a patient in the ER that was pregnant, 6 months pregnant, and that had abdominal pain. She was sent to X-ray, which maybe was not the best idea. She was sent to the lab, she was sent everywhere. In any case, to say one short story, there was actually no indication that there was something major going on. And therefore, the patient was sent back. Now, I repeat, that was a resident of my department who was used to seeing those complications, and that patient was sent home. She came back the next day, again, 6 months pregnant. She came back 2 days later and 3 days later. And then, always the same thing, negative observation. Patient was sent home and eventually was sent to another hospital. She was then operated on in an emergency, and obviously she had an internal hernia that had formed a nice little knot, and therefore there was a good part of the bowel that was black and that needed resection. Not only that, but also the baby didn't make it. And the risk of that type of approach is when you have a resident, you have to make sure that the resident is, first of all, experienced, and second, is not afraid of longer operative times. So he should not be lazy, or she should not be lazy. Okay, so why should we shift from a multiple anastomosis to single anastomosis, laparoscopic metabolic bariatric surgery? And I'll just briefly mention the well-known duodenal-ileal, or SADI, the sleeve-ileal, or SASI, and also, again, the OAGB that Rutledge, as you know, called the mini gastric bypass. And what are the characteristics? They are that there is usually one layer anastomosis, which simplifies things, which makes sure that the anatomy is more easily recognizable, and therefore there is less risk. The bodily aggression is limited, and I saw a study, I think it was last month, where we see that the risks for the patient with OAGB in terms of morbidity are comparable to the complications, or alleged complications, of the medication. And when I talk about medication, I talk about GLP-1, etc., obviously. Then, let's go on. Why should we shift to single anastomosis? Surgical logic. We're simple people, surgeons, so we want to keep it simple. So since simplicity wins, it's obvious that we have the tendency to opt for a OAGB. The complication profile is also, I think, typical, and I would say it has to do with especially metabolic issues. We heard about the bowel already, but there are other issues possible with the OAGB because of technical issues. And I've noticed that most surgeons have a peculiar technique to do the single anastomosis of the OAGB, and many things are neglected. For instance, the length of the gastric pouch is neglected. The dissection at the esogastric location is also neglected. And it took a while before we saw advancements in surgical technique. And we will place this train here because in Spain there's been a lot of advances in surgical technique compared to the techniques known from, for instance, Rutledge and others. Physiologic insights. There is a restriction versus malabsorption, was briefly mentioned by my colleague Wierens from Holland. But I must say that nowadays we don't think that the distinction between restriction and malabsorption should still be kept. I think that what we need to do is we need to adjust the technique of the patient, the volumes of the limbs, and not necessarily, except in extreme cases, look for the issue of malabsorption or restriction. Current evidence shows that there's more and more reports on the OAGB procedure, and except for France, where the procedure is still forbidden, we see that lots of surgeons actually have switched from the more complicated Roman gastric bypass to the OAGB. The conclusion in Europe, I'm not saying France, but in Europe, is that there's clearly a philosophical shift, and the OAGB is no longer considered an unlawful procedure. And the typically alleged risks of biliary reflux are many fewer than thought before. And in most studies, when we do meta-analysis, we see that usually the incidence is about 4% of the significant biliary reflux. And also, what's important is that when you have biliary reflux, is there something you can do? And yes, there is. There's medication, and there's also, and that's important, we just heard about the fact that the sleeve is not reversible. Well, OAGB is reversible. And I know you did just one, you said, a revision of, is that what you said earlier? The reversal. Yeah, okay. And, but it is a procedure that is feasible, and we've done more than 100 of those. And why is that? Because we get quite a lot of referrals from other centers, especially for treatment of this complication. Then the simplicity wins. We already mentioned that. Why? There's a reduced number of anastomosis. There's a reduced time, operative time, obviously, because of the simpler anatomy that is induced. There's less technically demanding aspect of the procedure because of the fact that there's just one anastomosis. And we see that the outcomes are comparable with the outcomes of Roux-en-Y gastric bypass. And for that, I reviewed the paper. It hasn't been published yet, but I reviewed a serious paper that showed that actually the logic that biliary reflux is automatically what follows the OAGB, it's not really true. And when we do a serious study, we see that that is indeed not the case. Complication profile. Each anastomosis adds risks, so that's why it's simpler, obviously, to do an OAGB. The rulum, we already mentioned that, can induce a significant risk of internal hernias. And don't forget, when we have an anastomosis, there's blood supply to the anastomosis, and that means that there is a mesenteric base. When you have a mesenteric base, that means there can be gaps in between the elements of that base, and there's a hidden danger for obstruction and increased, especially during pregnancy, which I already mentioned. Single anastomosis reduces these risks, and there are technical advancements. There's different approaches possible because of change in suture material, changes in tools. We have the robots. The techniques have become quite standardized. They're easier reproducible and simpler. There is anatomical, again, reversibility. I repeat that, but it's an important, to me, it's an important factor. And it allows for complementary procedures. As I said, there's the OAGB that you can complement by other procedures like SADI and SASI. Physiological insights, I'll zip through it because I see I passed my time. There's metabolic effects are driven by the hormone that we already mentioned earlier today. There's, of course, the incretins, GLP-1, PYY, and more are more important than anatomy, and that's why I repeat that this actually, I think, excludes the importance of restriction and malabsorption. There's new molecules that are being researched, and that's another thing. This is really a procedure that we can adjust day by day, I would say. And the use of terazepatide is one example of that. Rapid nutrient delivery is key, so dumping is still present and can be a significant element in the weight loss process. Complex reconstructions are not always needed, and usually a simple OAGB is all that we need. The current evidence, shorter operative time, as I said, easier reproducible, fewer complications, comparable or better weight loss than Roux-en-Y, similar diabetes and other comorbidity remission rates, and endorsed by now and recognized by the large conventions like IFSO and ASMBS. And so, to conclude, we come from maximum reconstruction, Roux-en-Y gastric bypass, to minimum reconstruction, and we do what's just needed. So we have the minimum necessary intervention. Function over anatomical complexity is important. We have to not to brag that we are able to do a complicated procedure with multiple anastomosis, for instance, but we have a procedure that is functionally very acceptable, very active, and comparable to the Roux-en-Y. I'll leave it here because I see that my time is over.
Thank you very much, Jacques, for the excellent talk. Any questions from the audience? I had one question while other people are thinking. Obviously, we talked of the whole concept and the physiology. The one thing which we probably didn't touch on the hiatus hernia, because I think that's one of the questions we all think of.
Yeah.
That if you have an incidental finding, no significant reflux, you're doing OAGB and you find a 2-centimeter hiatus hernia, would you go and then dissect and repair it? Or from your experience and from now, would you say no, leave it and proceed? And probably that same applies for Roux-en-Y as well.
Yeah, excellent question. But I must say that when there is no, you said there's no reflux, right?
So no
Okay,
significant
so it's
history.
just an
and you
anatomical
are,
finding.
in now and you have a 2-centimeter hiatus hernia.
Okay,
Because
so
there's a
that's
debate that if you see it,
Yeah.
you should go and dissect and repair it. So
No, you
what-
should limit that. I think you should limit it.
So
And,
not-
yeah.
okay.
But then on the other hand, when you have, you know, the impression that you have a quite significant hydral hernia, don't hesitate to go and look a little bit closer, because otherwise there's no way you're going to make a nice and long pouch, gastric pouch.
Okay. Thank you. Andres?
Yes, thank you
Thank you,
for
Jack.
the
Okay.
opens. Thank you very
You
much.
can- you
Oh.
can-
So we will move to the next presentation. Dr. Osorio from Barcelona, Javier, is going to speak about the preservation or not of the pylorus after sleeve gastrectomy when converting a sleeve gastrectomy. Javier?
Thank you very much, Andres. Thank you very much, Chetan. It's a real honor to be here today in this outstanding table talking about, in my case, SADIs, because what I was asked about is, if I have a sleeve, this sleeve has failed, why should we preserve the pylorus? Why should we convert it to a SADIs instead of a Roux-en-Y or Roux-en-Y bypass or HEPP? So, historically, we started doing DS after a failed sleeve because the sleeve was meant to be the first step for that. So it was the natural thing to do. Sleeve was the first step for a DS. If the sleeve fails, what else to do than a DS? So that was the experience that we had in Belviche, my former hospital. And then we learned from Andrés Sánchez Pernaute and Antonio Torres in Madrid that we could simplify the DS into a SADIs, which was much simpler, with very similar results as we saw in their first publication of revisional SADIs, or second step SADIs after the sleeve, with very good results with 70% excess weight loss in the long term. So the same thing we saw with the Vallebron experience also in Barcelona. Very good results in a short series, of course, but both papers had something in common, that they started with 2 meters, 2.5 meters mixed, and even though results were very good, the nutritional effects on patients was somehow a little worrying, because they had some issues with diarrheas, intractable diarrheas, malnutrition. So from the beginning in our hospital, we started with SADIs 3 meters, common limb, for primary and revisional, because we wanted to mimic the 3 meters total alimentary limb of DS. And we had the previous experience of some issues with 2 meters and 2.5 meters. Of course, at that time, we didn't compare 2 meters and 2.5 meters. All those was mixed, so we decided 3 meters for everyone. And the first time we revised retrospectively our revisional experience with 101 patients submitted either to DS, which was a little bit, as you see, an historical series, compared to 3 meters SADIs, the experience was a little disappointing in terms of efficacy. As you see here, and this is just retrospective, DS, which has a longer follow-up, has excellent results in the long term, but SADIS, even though 3 meters at the beginning, it was very promising, but then it came back to the dotted line, which was the time in which the second step was indicated. And that was a little bit worrying. It had to be with our subjective experience, but when we analyzed it, we thought that, as Chetan was saying before, we have to explain our mistakes. I think that we had a mistake doing 3 meters for everyone, for everybody. I think that, as the French understood afterwards, you have to tailor your common limb. So maybe 3 meters for primary, under 50, it's okay, but over 50 for primary or revisional, it had to be 2.5 meters. We have learned that 2.5 meters is safe. 2 meters is dangerous, isn't it, Andres? But 2.5 meters is reasonably safe and maybe more effective. So this is the same series I was talking to you about. Initial pre-sleep BMI was very, very high, was 56 mean for both groups, and I was telling you the DS was more effective, not just in weight control, but also in diabetes control. Complications in the short terms for DS and SADIS was similar, and biliary reflux was very anecdotal in SADIS. It was 2 cases only, but of course this is retrospective. I think that we should not obtain the conclusion that biliary reflux after loop reconstruction is low just because our retrospective data say so. We lack prospective serious data. We also saw that we had no dumping, not anastomotic ulcer at all because of pylorus preservation, but this is retrospective data also. So we also had this propensity score match analysis in our experience, comparing SADIS 1-step versus 2-step, 3 meters for all. We also saw that for comparable patients, for comparable characteristic in the first time, from the beginning, 1-step 3 meters was much more effective than 2-step 3 meters. So, and also we saw in this in 400 SADIS cases that we had no reinterventions for acid GERD. We had 3 reinterventions in SADIS for biliary reflux, which is very low, less than 1%, no dumping, and no anastomotic ulcer. So this is more than 400 cases. It has to do with pylorus preservations, I'm sure, but also it's retrospective data. The long-term follow-up of SADIS of Andres tells us that not only SADIS at 2.5 meters is very effective as primary and revisional technique with more than 70% excess weight loss in the long term, but also that there is no biliary reflux with the pylor interposition, no dumping, and no anastomotic ulcer. Only 1 revisional surgery for acid GERD. They had, of course, revisional surgery for intractable diarrhea in 13 cases, but they were mostly for 2 meters common limb SADIS. So as I was telling you, it's very promising. 2.5 meters SADIS as revisional after sleep is very promising, as very good results and very good equilibrium with low long-term morbidity because of pylorus interposition or preservation. But as I was telling you about, this is retrospective. We need prospective data with thorough follow-up. Of course, we had to look at France, because even though there is no comparison between SADIS and OAGBP direct, but we have both of them compared separately, prospectively, with Roux-en-Y gastric bypass. And this is the SADIS versus Roux-en-Y gastric bypass of Maud Robert and company. And as you know, SADIS is behaving better than Roux-en-Y for weight control at the midterm. They learned from our mistake, so they didn't do 3 meters common limb for everyone. They did 3 meters for under 50 primary, and they did 2.5 meters for over 50 primary or revisional. So I think this is a very wise approach for this study, even though it's it's not too homogeneous, but it's a very wise approach, learning for our past mistakes. But everybody knows that SADIs is effective. We don't have to convince our endocrinologists that SADIs is effective. They know. So we have to convince them that it is safe. So comparing this study, short-term morbidity was a little bit higher after SADIs, but of course it was the beginning of their learning curve. But this is most importantly, long-term complications after SADIs was much lower than Roux-en-Y gastric bypass. And this is mixed primary and revisional, as I was telling you, but this is at the expense, of course, of preserving the pylorus. Less dumping, less hypoglycemia, less chronic abdominal pain, less internal hernias. So maybe in this perspective, promising data, SADIs is showing us that it's behaving as more effective and less complications at the long term. Now, if you look at the omega, as I was telling you, comparison is separate in two studies. We see that also OAGB has more long-term complications. Of course, it was 2 meters biliary, which is, we know after too much, but we had, they had to stop the study because of intractable higher diarrhea and nutritional complications and reflux. And this is very important. If we see also the data at 5 years, we have very prospective objectivation of biliary reflux, which is something that we don't see in retrospective studies, but we do see in this prospective study with systematic endoscopy. We see that we have 19% gastritis in the OAGB group, 10% esophagitis, and quite a number, 16% of presence of biliary in the stomach in the systematic endoscopy in this study. So biliary reflux after GBP shouldn't be dismissed as only 4% or something like that, because this data is based on non-systematic and retrospective data. So I would think we could conclude that SADIs as a revisional technique after a facelift is safe in the short term, with a low morbidity in the short term comparable to primary SADIs, that it is effective at 2.5 meters, as we see with the experience of Andrés, of the French study, and our colleagues from Vall d'Hebron, not my own experience, in which 3 meters is maybe less effective than DS as a revisional surgery, not as a primary surgery of patients under 50, that it has less long-term complications than Roux-en-Y gastric bypass and OAGB. So what should I do if I face a facelift in my practice with insufficient weight loss or weight regain? I would consider maybe, based on the previous experience, if the initial BMI is very high, and the present BMI, as we discussed with, I see Ainiche commenting that also the actual BMI is important. Yes, you're right. We had to consider not just the initial BMI, but also the actual BMI. But if we see that the actual BMI and the initial BMI are reasonable, we could offer them a 3 meters SADIs as revisional. If we see that we have a big enemy with very high initial BMI, persistent diabetes, longer age, then we could tailor a DS or a 2.5 meters SADIs, which is, as I say, I think the best long limb length for revisional surgery. Of course, to offer them a 2.5 meters and a SADIs, my opinion is that we have to have a patient who is compromised with follow-up. We have to have a very compliant patient that is going to pay for the supplementations, because otherwise maybe 3 meters is wiser if we don't trust the patient to be followed by our team. Of course, if we've had a significant GERD after SADIs, after sleeve, I think we have no option that offer them a Roux-en-Y gastric bypass. This is something I agree that it's not easy to define what is a significant GERD after a SADI-S, but if we consider that this patient has a significant GERD, we should offer them a Roux-en-Y gastric bypass. And of course, the good thing about SADI-S, TS, and sleeve is that they are three excellent techniques which are in line. So we can convert to one another very easily. We can convert to SADI-S from SADI-S to a DS if we have a biliary reflux, and we also could consider converting to a DS in case of insufficient weight loss, even though there is not much evidence about that. So I think that SADI-S is in line with three very old, very recognized, very based on proofs techniques, which is sleeve, SADI-S, and DS, that it is very effective in 2.5 meters as a revisional technique for sleeve, and it has all the advantages in the long term of preserving the pylorus. Thank you very much.
Thank you very much, Javier, for the presentation. Just one question before I pass on to Carl. You know, with being distal to pylorus and with the data you have, you do show that there is no refluxes and no marginal ulcers. But then we also show in the algorithm that if you have reflux after sleeve, you don't tend to do SADI and you would just do a bypass. Would SADI still not be a good option in that scenario?
It's a very, very good question. My opinion, my personal opinion is that, but this is very subjective, based on our retrospective data, is that if you ligate and transect the right gastric artery, the position of your sleeve is so straight that I think that acid reflux is less than, even less than SADI, than sleeve. But having said so, if you have a significant GERD after sleeve, you have to consider that maybe you have some problem with kinking or with the shape of your stomach, even though you cannot objectivate that. So you are not going to correct it doing a SADI-S. So I think you have to correct both things. If your GERD is important, and we know, we have enough data to see that the best way of correcting acid GERD after sleeve is a Roux-en-Y gastric bypass. So I think we should not risk at that point.
Thank you. Carl?
Thank you. You have nicely shown the advantages of preserving the pylorus, but then you have shown this data comparison Roux-en-Y against SADI-S, and on the long run, after 5 years, there have been 18% of reflux issues with the SADI-S. So isn't it somehow worrisome that you have still this problem on the long run with the SADI-S with almost 20% of reflux issues?
Yes. You're talking about the French study, or?
Yes.
Yes. Of course, this was based on prospective questionnaires. It is true that they didn't need revisional surgery as they did in the OAGBP. In the OAGBP prospective study, they did need to convert it because of biliary reflux. The other ones were treated with IBP, as it is in our practice, with more than 400. We just converted one case for acid reflux, so it's not so terrible as it is the biliary reflux. When biliary reflux is present in the prospective French study and our own experience, it's a big issue. So they needed revision for that.
So you treat many of them with PPI on the long run? So
yes,
no.
Around 20%.
Okay, thank you.
Gerhard Braga, Vienna, great talk. You partially answered my question already, because we also see much more reflux after sleeve than after SADI-S. And you mentioned that taking down the right gastric artery straightens the sleeve, or the sleeve part of the SADI. So my question is more to Andres, who does not take down the right gastric artery. Do you
not
see
all the
a
time.
difference in the long-term run between sleeve gastrectomy and SADI-S, reflux-wise?
Well, thank you. There are two kinds of patients. The patient submitted to primary surgery has a wider sleeve, and that's not an issue. The patient submitted to secondary studies to revisional surgery after sleeve gastrectomy is always a mystery, because you don't know nothing about that sleeve gastrectomy and how it is behaving. I think it's important in the pathogenesis of that reflux, the weight of the patient. There are many patients that we see that had a good response to the sleeve gastrectomy, lose weight, and then reflux disappears, and then have weight recurrence, and then reflux appears again. So in those patients, I don't mind about GERD because it's going to disappear with the weight loss. I like the issue of the right gastric artery, which I never divide, because we have observed also that there's a quite different anatomy in the stomach after sleeve gastrectomy and after a SADI without division of the artery, because it's also quite straight, and you saw our data. Well, I'm not answering the question because it's difficult to answer it. Just in case I have any doubt, I do not convert to a SADIS with the minimal doubt.
But Gerard, if I can, I think, Gerard, that this question could be answered by Marta Guimarães and their team, because they did a comparative study comparing SADIS with right gastric artery ligation versus no gastric artery ligation. They observed that the competence of the pylorus is comparable, so the nerve is preserved, and they will show us what is in the long term the functional comparison between both groups.
Excellent talk, thanks. First, a statement. Looking at your algorithm, in my experience, most people that have a failed sleeve fail for one of two reasons. It's either recurrent weight gain, but more than 50% have severe reflux. So the side arm that you're showing on the left here is maybe the most important arm, as is shown by Ralph Peterle and Paulina. So if you're fair about complication rates, which is the safety part of doing bariatric surgery, then you should add up all the complications that you have in your sleeve gastrectomies, which, as you have shown, is about 10% cleft end of 3 and up, add it to the 6% that you have in your SADIs. Adding that up is 16% complication rate. In an OAGB, primary OAGB, in our natural registry in the Netherlands, it's roughly around 1.5%. So you're 15 times higher than that in complication rate.
Complications of sleeve, you're rating them on what?
That's what you have shown. You had 10% complication rate in
For sleeve?
For sleeves. Your complication rate from your slides. So, and it's probably not that high, but even if it's somewhere around
you
6
say the
or
short term,
7%,
sorry, you say the short term complications, or the long term complications.
Well, it complicates things too much, I think, for this discussion, but you should add them up together. You're right. But my challenge to you is, you're saying a SADI-S is a safe procedure, but having complication rates around 6% is unacceptably high, isn't it? It's 4 times what you should have doing an OAGB.
If you say in the short term, it depends on how you measure complications. If you're really thorough in measuring all complications, I don't think any bariatric surgery has less than 6% global complication. I don't think it's a high complication rate in the short term. 6%. Do you?
I do think so. And you compared, and justly so, with the Omega trial. Their main complication was nutritional deficiencies and some reflux, which is true. But it doesn't, in my practice, doing 50 procedures a week, 200 in a month, a complication rate of 5 to 6%.
Talking about the Omega, of course, you're right that the Omega, it was 2 meters biliary for the OGBP, of course. But do you measure all the bowel? Do you feel confident? Do you do 1.5 meters normally for biliary?
1.5 meters, yes.
And you never measure the whole of the bowel?
No, I'm too lazy for that.
Well, I think that doing a long biliary limb without measuring the rest, it's somehow risky. And this is what we learned in the Omega. If you follow your patients and you don't know which is your common limb, you risk to have some issues with that, because you don't know your common limb at all. So it's very heterogeneous for every patient. So
Okay, I probably have to stop here. But
No,
that's the
go on.
trade-off. You probably agree. That's the trade-off. Having a little bit more weight loss compared to OGB, compared to, and that's the trade-off, a little bit more complications. I would choose the little bit less weight loss for more safety.
Thank you. Last question. Only a quick comment. Javier, very glad to hear that I think it's a nice clue. 250 of comparing with the adenal switch at the beginning of the paper, it was 300. And maybe the results of weight loss are similar with the DS. But I think the clue here is when you have a patient with it's not going to be a good follow-up or vitamins, don't do it below 300 centimeters. I think it's very safe that way. Thank you very much.
And this is something that when you have a revision, you know, as my colleague, Dr. Ibarzabal, always says, when you do 2 steps, at least you know what is the compromise of the patient. Exactly. So you can tailor it on that information that you also already have.
That's important.
10 minutes late or something like that.
Thank you very much.
Thank you very much.
Introduce Carl.
Yeah, and now I have the pleasure of inviting Carl to talk about length matters. So Carl is a surgeon from Germany, past president of the MGB-OGB club. Welcome, Carl.
So thank you very much for the introducing words, the auditorium. Thanks also to Professor Salminen and Professor Okana for having invited me to talk about length matters concerning the OAGB procedure. My disclosures without influence on this presentation. My IFSO accorded case mix disclosure showing the majority of my cases nowadays were conversions, OAGB, and among the other primary bariatric procedures. And as all you know, as in other types of gastric bypass, also in OAGB, a short BP limb means less deficiencies, perhaps less long-term weight loss, perhaps less remission of related disorders, and perhaps elevated recurrent weight gain risk. For the longer BP limb, of course, it's the opposite on the balance. So the topic is not as fresh as that. So about 8 years ago, I had the honor to author this chapter in this book about the ideal length of the jejunal limb in MGB, and I doubt whether I can give you an answer 8 years later now in this place. And always we have to remember that the total bowel length, it differs very much. About 3 meters to 12 meters length have been measured in literature. I did a few days ago PubMed search on OAGB and limb length, found about 100 items on that. And I focused on reviews, meta-analysis, and guidelines, and I liked quite a lot this review from Marc Fouquet from Belgium, because he classified the articles, the papers in different groups. First, the traditional fixed limb length, which was introduced by the inventor of the procedure, Rutledge, in 1997. He always did 200 centimeters. And you can see in the second last column, in the beginning, the studies were more with 200 centimeters, and nowadays we have series with 150 centimeters and quite successful long-term outcome, like the paper from Liacré from southern France. He followed the patients 8 years and got excellent excess weight loss, whereas excess weight loss is not the ideal measurement of weight loss, as all we know, because it's BMI dependent. Another way to approach is a tailoring of the limb length on BMI at baseline. So the first who did this quite successful was Wai-Chi Lee from Taiwan. Almost 20 years ago, he grouped his patients in 3 different length groups depending on BMI, and there are other series as well showing all about the same excess weight loss. And another way to tailor is measuring the total small bowel length, as it did extensively the group from Professor Carbajo in Valladolid in Spain. And I think most of you will know this paper with a 12-year follow-up in 1,200 patients with surprisingly little nutritional deficiencies and excellent results. And after tailoring, they did quite a very long exclusion of small bowel, about 300 centimeters in the BP limb length, remaining 200 to 250 centimeters in the common channel. So they took almost 60% of the total bowel length in the BP limb. There is a fourth approach to tailor the bypass. It would be the fixed common channel length, meaning measuring the small bowel upwards from the ileocecal valve, 300 or 400 centimeters, also giving excellent results, but this method has not become very popular. So in conclusion, Fouquet, he says the ideal or optimal biliopancreatic limb length in OAGB still needs to be defined. So, and up to now, 200 centimeters is still the most commonly used length, whereas shorter limb lengths, they are more popular nowadays. What does IFSO says to that? We had in 2019 in Hamburg a meeting of 52 experts answering to 90 questions on OAGB, and concerning the limb length, the statement was that a BP limb length less than 150 centimeters would be comparable to a Roux-en-Y standard gastric bypass, whereas longer than 150 centimeters would be more similar to BPD or duodenal switch procedure. And 4 years later, in 2023, again, 43 experts of IFSO met in Hamburg, published this paper in 2024, asking on 136 questions, not only OAGB. OAGB was only a small part of this Delphi study. And concerning OAGB, the statement was that in OAGB, 200 centimeters or longer may increase the risk of protein deficiency, with 100% agreement by 39 of 43 voting experts. The group of Kamal Mahava from UK, he is more or less confirming this tendency to shorter limb lengths. They did this study and found in the review that longer BP limb lengths, especially more than 200 centimeters, are associated with a higher risk of malnutrition, and they are favoring a shorter limb lengths like 150 centimeters or even shorter. So is this end of discussion, 150 centimeters for all and finished? I don't think so. If I go on and check the other side of the literature, I found from year 2025, so 1 year ago, this review from the Mexican group. They studied 67 papers out of 3,700, and they found at least that longer limb lengths enhance the weight loss, but of course they found increased nutritional risk in their review. If you go back in the past, we found this series with about 1,000 or up to 1,520 cohorts cases of OAGB with up to 6-year follow-up, and they did quite long limb lengths with more than 250 or even more than 300 centimeters bowel exclusion, and they had a maximum revision rate for malnutrition in only as low as 0.4%. So if I look in this review from Salman Emirates, comparing 150 centimeter versus 200 centimeter OAGB, with including meta-analysis. They meta-analyzed 8 studies with 2,599 patients, a median follow-up 24 months, and they found a highly significantly better total weight loss with 200 centimeter bypass, whereas the nutritional deficiencies were quite low. Only folate and ferritin levels were significantly worse in the 200 centimeter group of OAGB. We heard already about the Omega trial from France. It wasn't only the 2-year study, which showed this 21% of nutritional deficiencies, whereas it was really only about 7%, because 21% is focused on 42 complications in the long run, and out of that, 21 were nutritional. But a very important message is that now, 2 years ago, the 5-year results came out of the Omega trial, and surprisingly, in the 200 centimeter OAGB, the nutritional deficiencies were as low or as high as in the standard Roux-en-Y gastric bypass. So this seemed having been disappeared. So with all this controversy, a few days ago, I checked on our own patients, and we had almost 600 OAGB patients with BMI-tailored OAGB out of more than 2,000, with completed 3-year follow-up. And of course, there was significant difference in the baseline BMI, so being higher, almost 55 in the more than 200 centimeter group. And the weight also was 155 versus 136 in the more than 200 centimeter group. And of course, operation time was also significantly longer, meaning 7 minutes more in the more than 200 centimeter group with a higher BMI. And we did Mann-Whitney comparison of this data, and we found 6.5 BMI points better weight loss after 3 years in the longer bypasses. So the longer bypasses had actually a median length of bypass of almost 240 centimeters, versus the shorter group had 180 centimeters median bypass length. So there was better weight loss after 3 years in the longer bypass. And looking into any nutritional deficiencies, meaning even one time the iron was too low, something like that, had to be better supplemented, we found no significant difference. Slightly higher in the longer group, but no significant so far. So coming to the conclusions, there have been applications of BP limb lengths and OAGB successfully with lengths from 150 to 350 centimeters. Malnutrition problems are published, especially with a BP limb longer or equal to 200 centimeters. There is a tendency towards fixed 150 centimeters, that is clear. And with a limb length more than 200 centimeters, it's often recommended to measure the total bowel limb length. And there are the options of systematic tailoring according either to total bowel length and or to the BMI at baseline. The extreme variation showed is a Spanish OAGB from Carbajo with a biliopancreatic limb length of almost 60 centimeters of the total bowel length. And we have to consider age, socio-cultural factors, and in my opinion, the quality of follow-up when you choose the length of your excluded small bowel in OAGB. We surgeons are always afraid of malnutrition, whereas our patients are more afraid of suboptimal clinical response. And so I am sorry, there is no final evidence so far to demonstrate. Thank you very much.
Thank you very much, Carl. I think there is a question coming.
Congratulations, very clear lecture. With your knowledge, to obtain similar results with Roux-en-Y gastric bypass, comparing to OAGB, what is the limb of length with the same length of the pouch?
The length of the pouch is a question?
I mean, imagine if you would like to obtain the same result in terms of weight loss after Rule Y. You have the same length of the pouch in both, thin, long gastric pouch. Which length of the loops in Rule Y would you recommend?
In the Roux-en-Y gastric bypass, which I would recommend, actually we do Roux-en-Y gastric bypasses as well, almost in the same dimension, and we do the reversed Roux-en-Y gastric bypass since 12 years, meaning we do a long biliopancreatic limb, and the Roux limb always we do quite short, like 50 to 60 centimeters only.
So what's your standard BP limb in Roux-en-Y nowadays?
It's BMI depending between 140 and 160 centimeters.
Well,
and 50 centimeter elementary limb.
The reason of my question was that most studies compare the long BP limb in OAGB and shorter BP limb in Roux-en-Y, which I found unjust. That's why I asked this question.
We published actually these two groups with this long Roux-en-Y gastric bypass with a total bowel length, total bypass length additionally of 250 centimeters versus our quite long OAGBs with 240 centimeters in mean, and they got the same weight loss results concerning total bowel weight loss.
Thank you. I think to answer your question as well, and probably Fred touched on that as well. So since doing OAGB, my Roux-en-Y pouch has become longer and longer as well, and I think with good result. And BP limb as well, I started with 50 for Roux-en-Ys. Now I'm at 75. At some point I do want to go at 100 to have that uniformity. But I think that's the change coming, and I think you would agree, or who here does, in your Roux-en-Y, does a long gastric pouch? Can you raise your hands? Okay, so yeah, so there's still a lot of people who are doing shorter. Try longer and publish your results. I think you'll be surprised, pleasantly surprised, I would say.
Just adding information, if you have a difficult patient with a high BMI and a bad visceral fat distribution type, we are doing like facing for OAGB, but if the patient has some kind of reflux issues or so, we check during the operation if it's not feasible to do Roux-en-Y, and after, meaning ending the OAGB part, you can still divert it and just cut off the BP limb and anastomose it to the downgoing common limb. So I mean like a kind of diverted OAGB with the same long length.
And a follow-up to that question again, how many of people here have a fixed limb, a BP limb for their OAGBs? Again, can you have and do you tailor that according to your BMI, like 50 BMI, or you're just fixed? Okay, fine, thank you.
Thank you.
Thank you, Carl. Thank you, and I obviously have the pleasure now to introduce Andres, who is the chair for this course.
Thank you, Chetan. Thank you for coming to the course. Well, yo no lo veo aquí, claro. Aquí. ¿Me das un micrófono? Un micrófono, sí.
That screen is not working. No, it's my last location. Oh yeah, you connected it.
Both to be the most difficult or the most challenging parts of the SADIs, and the reason for what many people are not doing this operation probably. I don't think it's working. Yes? No? I'm sorry. Well, this is just to show what I tell my residents usually about the duodenum. The duodenum is the most noble part of the digestive system, because when it presents us in an emergency operation perforated, you don't even need to suture it. Just put a small patch of fat on it and it's going to heal. And I think this doesn't happen with any other part of the digestive tract. So it's a very noble organ, and no one has to be afraid of dissecting and suturing it. But I admit that most people, when you speak about the duodenum, think about the Whipple procedure, which is difficult, and not about the duodenal ulcer, which is a very simple disease to diagnose and to treat. And I think we have to move to the duodenal ulcer to simplify our access to the duodenum. Oh, I'm sorry. Well, when we perform an anastomosis to the duodenum or to whatever organ, we have to look for a short-term safety of the anastomosis. So we have to perform a careful technique. We have to consider the tissue vascularization, and we have to avoid tension on the anastomosis edges, because tension is going to limit vascularization also. So it is really the same. For SADIs, I operate always and initiate the operation in between the legs of the patient with the patient head up, and I usually 4 trokers. I think you will see here the trokers. Yes, if you see, I have the liver retractor here on my left hand for the upper part of the operation, and these 3 trokers are oriented to the most important part of the operation, which is the duodenum, for duodenal dissection and for the anastomosis. The scope in the middle, right hand and left hand. My initial approach is to continue the dissection of the greater curve of the stomach into the duodenum. So I dissect the whole left part of the duodenum until I reach or complete D1. And then I will come to the back of the duodenum, raise the duodenum in right angles with the pancreas. If possible, identify the GD artery and then work on the right part of the duodenopancreatic angle to pass to the hepatoduodenal ligament. You will see here in a video, after the sleeve dissection or the stomach dissection is almost completed, we come to continue this dissection of the great curve of the duodenum, of the stomach into the duodenum. This is a very safe area because there are no important structures there. You are only going to find the pancreas, which is going to be the end of our dissection. The dissection is not limited by the presence of the GD artery, but of the presence of the pancreatic tissue into the duodenal wall. You see, we reach almost the gallbladder, and then when this is complete, we come to the posterior part. If possible, we identify the artery. If not possible, don't care about that. The assistant is retracting the liver. We complete this dissection a bit further. And we will see probably the artery running here. The artery is a landmark that warrants that you are going in the safe plane. If you go above the artery, you are not going, almost never, going to have any problems in the hepatoduodenal artery, ligament. All these vessels are ligated. I prefer to use this energy system because it helps with the retroperitoneal dissection. And this is almost a live video. I mean, this is poorly edited, so it's the time you take into duodenal dissection. Of course, it's an easy patient. It's random. I didn't choose it. So the artery is running here, I think, and this is, as I told you, the limit, the pancreas here. So our aim is to open this hole. If dissection is complete in the right part, it is going to be easy to open the hole here. I preserve, as we spoke before, the right gastric vessels, divide the supraduodenal artery here, usually. And here, dissection goes a bit up and a bit to the right to try to avoid the bile duct, which is somewhere around there. So this is our complete dissection. To divide the duodenum, I introduced the stapler from the left subcostal trocar. Why? I try to represent it here. If you go from left to right, as you will see here, you will not have any problem with the column. If you introduce the stapler through the right trocar, you will have problems with the column here. It will be much more difficult. I find it difficult. And you will leave a longer duodenal stump. And a long duodenal stump is probably going to be more dangerous in terms of possible leaks. So this is the division of the duodenum. I have changed recently, I don't know why, but I have changed the purple cartridge for the tan cartridge, trying to have a lower number of clots in the duodenum or a small bleeding in the duodenal stump. And always try to put the stapler in right angles with the longer axis of the duodenum, although many times it's not possible. You see, there should be never any problem with the bile duct, never. I use Buscopan during the operation to try to relax the smooth muscle of the small bowel. And I find that if this is relaxed, you obtain a longer duodenal cuff to do a safer and simpler anastomosis. That's the reason. You see, there's no reason to divide the artery here. This is going to come well far from the liver. To do the anastomosis, I turn to the left-hand side of the patient. Sometimes I do it from in between the legs, but I find it less comfortable. And I measure the small bowel, putting the scope here, and then I turn the scope to the middle and use my left hand and my right hand to do the anastomosis. The anastomosis can be hand-sewn or stapled. I started doing it stapled because I thought I was not going to be able, I was not so skillful to be able to do a hand-sewn anastomosis, a laparoscopic hand-sewn anastomosis back in 2005 when I started doing the duodenal switch. And then I changed to hand-sewn when I considered I was able to do it. I think it's a very easy anastomosis, always double layer. And for staple anastomosis, I use a 30 millimeters linear stapler, always the tan cartridge, the vascular cartridge. And I have heard that there's people using a smaller cartridge that is made for pediatric vascular surgery with only 2 staple lines, and it's a very low profile cartridge. And when we find any problem in putting the duodenal cuff into the stapler, you will see how to deal with this situation now. We add a stitch at the middle of the staple line. As you see, this is a double layer using V-lock or PDS. And the same for the closure of the defect after stapling the duodenum. With 2 centimeters of staple line is usually enough to have a wide anastomosis. This anastomosis is not limited by its size. I think we have no strictures. It's limited by the pylorus. And the pylorus admits the opens for particles of 3 millimeters, so it should never be a problem. In hand-sewn anastomosis, it seems to be a bit wider. And you see how the duodenum has come well far from the liver, so we don't need to dissect it any further. And in cases that we have trouble with the staple line because it's turned down, some Colombian guys last week told me or suggested the possibility of putting this stitch in the middle or even 2 stitches to put the staple line up, and then it will be much easier to do the staple anastomosis. So I call it the Colombian stitch because they suggested in the OR, so, and it worked well. Just one or two stitches of PDS, and it will be much more easy to introduce the stapler from the left-hand side of the patient, as you saw. The only real problem of this anastomosis is tension, and tension always happens to be at that point. That is when you raise the small bowel to the proximity of the duodenum, and you can release this tension by open the greater omentum. I don't think it does any good because the omentum here is thin, and I prefer to do a kind of cattle blast maneuver, so dissecting the colon far away from the duodenum. It helps a lot. I had this idea once I operated a patient that had a malrotation, so it was really easy to put the small bowel up to do the anastomosis. So I sometimes do it when it's difficult, the anastomosis is difficult. And this is the possible division of the right gastric artery, which I do not recommend. And this is just to show you how even if you consider the anastomosis has no tension, you can find a small defect always at the same point that I told you before, is when you place the stage suture to raise the small bowel to come close to the duodenum to start the anastomosis, always in the same place. So this anastomosis should be a safe anastomosis if you follow the adequate steps for dissection and for the anastomosis. It should be both parts should be well vascularized, and it is well vascularized even if you do a division of the right gastric artery. We obtain the same results either hand-sewn or stapled, and I insist on the release tension as much as possible for obtaining a good result. Thank you very much.
Thank you very much, Andres, for the great talk. While he comes to the screen, I don't know whether I missed it or not. You know the duodenal stump after you divide, do you you just leave it and it's fine?
Never over
Okay, yes, fine.
Thank you very much. Very nice hints. I once had a very big difficulty to bring the ileum to the duodenal stump. And what I did was the division of the right gastric, and then I managed to do that. And is there any evidence not to do it?
No. Any evidence of?
Not to divide the right gastric?
I don't think so. No evidence. I think the studies from Marquesini and the experience from Javier and people from Belvice and Clinique demonstrate that there is no problem dividing the artery if you divide it at the root. I once had a case of a patient who suffered from a total, complete ischemia of the duodenal cuff. He came 1 week later to the hospital, and there was no leak, but the duodenum was black, totally black. I think I dissected it too much and too close to the duodenal wall, because you have to keep the arcade of the lesser curve. Well, also, it can be that you can divide the artery in a patient with obstruction of the left gastric. It can be an issue also. So that's the only thing.
And one more question about just avoiding doing the SADIs in the case you have very vast adhesions around the duodenum, like after previous biliary operations or previous cholecystectomy or some inflammations. I'm very big fan of SADIs, and patients do very well after this operation, surprisingly at the beginning for me. However, I had one leak at the duodenal stump in a patient who had a lot of adhesions around the duodenum. And I went to the literature afterwards, and there are some suggestions that if you find some adhesions, some bad situation around there, you should avoid doing SADIs. What's your opinion about this?
The same. I admit that I don't look for lesions in the small bowel or problems in the duodenum before starting the operation. There's people that go
first to the lower part of the abdomen to see if the ileum is free. You can manage of the small bowel. I do not. I also do not go to the duodenum to see it. If I come down dissecting the greater curve and go to the duodenum and find it impossible, I just leave a sleeve gastrectomy, which is a fantastic operation. I once completed the operation in a patient that had been submitted to an open left hepatectomy. It was a nightmare. I only did that because there were people around looking at the operation. They wanted to see the whole operation. And the patient suffered a post-operative perforation and had
A curse of workshops.
yeah, that's it. Life surgery is a problem.
Hello, Andres. Very nice presentation. Sometimes this video was very clear. It was beautiful, but sometimes I have seen doing the mechanical anastomosis, which can be difficult.
Yes.
Have you ever had a case in which you planned to do it mechanically and then you had to turn it to manually because of technical difficulties?
Yes, thank you, Javier. The first Hansun anastomosis I did in my life was because after firing the staple, everything was broken. I mean, a hole in the small bowel, a hole in the duodenum. On those days, I thought the best option was to open the patient and start doing an open surgery. But there was a guy also visiting me, a Colombian guy, and he told, what about that? You should do now a Hansun anastomosis. And I had never done it, and I found it very easy. So I shifted from mechanical to Hansun and started doing all cases Hansun. Now I do one and one. 2 days, two cases a day, one mechanical.
And since then that you have big experience, have you ever had this situation in which it was too difficult mechanically?
Yes, yes, very few cases, but I find difficult cases you should go manually always. For especially heavy patients, difficult patients, go manually. It's safer.
Thank you very much. And now I have a pleasure of inviting our good friend from Spain, again, Carlos. He's going to talk about lab or robot. We are running a bit behind time, so I'm going to be a bit stricter with time.
I think I'm going to be fast.
Thank you.
Can we turn the lights a little bit up? ¿Podemos bajar la luz, por favor? Well, thank you, Dr. Sanchez Pernaudo, Dr. Parmar. It's a pleasure and an honor, Dr. Jack Hempens. Lab or robot? I do right now, I'm Carlos Ferrini from Madrid. 100% of my surgeries are via robotic with the Da Vinci platform. And I think it's better. That's my conclusion today. I do a lot of SADIs at the time. With laparoscopic approach, I learned it at Clínico San Carlos, and I think the robot helps a lot at the most delicate or difficult part, the duodenal dissection, and also the anastomosis. We always do it manually, and that's I remember in laparoscopic approach, at that part, you was tired, it was a big patient, and with the robot, you get there and you know you have 5-7 minutes of anastomosis and that's it. Let's see if we can see the presentation. How many of the room do bariatric surgery with a robot? Okay, still very low percentage. So we are not going to fight. Laparoscopic is an excellent approach.
And while he's uploading his presentation, we are just told to remind you guys that can you please download the IFSO app and scan your QR code mainly so that you can get the credit and certification as well. So please do that. Carlos.
Well, sorry. I'm Carlos Ferrini. This is our first SADIs as our hospital 2018. My career was at Clínico San Carlos with Andres Sanchez Pernaudo and Dr. Torres. And of course, I grew up with the SADIs procedure. I see it normal. Well, this is not a fight, I've told you before. laparoscopic and robotic. I think if you have the robot, you need to use it. And if you have laparoscopy, you use that tool. So, this is the first robotic surgery by Dr. Hempen Kadir, almost 30 years ago. It was a gastric band. And, well, 28 years after, there was the conclusion was telesurgical procedures, it's feasible. And I think very important, because we never see it, is the ergonomic of the surgeon. That is very important. And the robot, most of the platform help you a lot with that issue. And one of the advantages in very heavy patients is the use of the robot. Because I'm going to show you a video. It's better for the thick abdominal wall. So in 2026, what do we have? Almost the same conclusion. There is right now no papers that can tell us today in bariatric surgery that the robot is better. But well, the several advantages, the robot remove the counterintuitive motion and instrument tremor, and it's very beneficial from the surgeon from the ergonomical point of view. This is the DB5, the last procedures. And the visualization, that's much better. You are your own cameraman. You can see it inside, and the 3D vision that is not comparable with a standard laparoscopy. And you can see here the wrist movement is almost at open surgery. It's exactly the same. So this is the first paper, 2007. 200 centimeters, but as we told before, it's not safe. And Dr. Jordi Tarasco published the first robotic SADIs in 2020. Very high BMI patient with hernia. And well, what do we have today? This is a paper comparison in robotic versus laparoscopic SADIs. And well, comparable safety in very revisional surgeries and high BMI patient. Longer operative time, but I think this is at the beginning. When you start with the robot, you hate it. That's true, because you're so used to the laparoscopic approach. But when you have your learning curve that is lesser, number of cases with the robot, you can get down a lot your operative time. And you need to trust it, the robot. You need to trust it to use it and to learn how to use it and to learn all the advantages that have. This about the operative time, Andre Teixeira from Orlando Health and Dr. Alexis Sanchez. We make a paper on the revision. I have my cases of robotic SADIs, and what do? We take my last pre-mentoring with him, robotic SADIs, and he telementored me 4 cases from Orlando Health. With at that time we did it with the Proximi app, but you can do it right now with the DB5. You can do telepresence directly from the console. And well, in 4 cases, he tell me, go this way, go faster. Of course, I know how to do the SADIs, but this guy do 600 per year, so he way more faster. And the results, really nice. That was my 10 before the telementoring, 31 minutes of duodenal dissection. That was we were comparing it then. And the 4 cases that he was with me from Orlando, and I was in Madrid, Orlando, Florida, USA. The first 4 cases, 12.5 minutes of duodenal dissection, so almost half, more than a half. And then I continue without him, and the mean time right now is 15 minutes with the row. So you can get lower your time, operating time with the robot, of course. And well, let's see a video, because I think it's the best way to demonstrate the robot. This is what I'm telling you, that help you a lot. The lifting of the thick abdominal wall in very high patients. You use SADIs or OAGBs and very higher BMI patient, and the robot helps you a lot with the thing. You can work with 10, 12 pressure on your intra-abdominal pressure, and the robot do the work. Well, this is the video. This is all our pictures of mine and cases, very high BMI. We always start, we put the liver retractor, we do full totally robotic, always. We always go to the ileocecal valve to see it. If we cannot find it from addition or something, we go to the trades and count. We can talk about later. And this patient was 250 from the ileocecal valve. We always fix to the radial momentum and check if you are going to have a no tension anastomosis. Then we start dissecting, as Dr. Pernaute showed you before, greater curvature to the duodenum. You get a little bit post-pyloric, and at the beginning it's difficult because you're usually to the lab instrument, energy instrument, but I think it's very, very useful, this type of energy in the robot. Not always you see the gastroduodenal artery as well as the video of Dr. Sanchez Pernaute, but well. Nowadays, I don't use the hook and in the SADIs, only use one, less expensive and better. Then we go to a lesser curvature, and we pass the duodenum. We never or try not to ligate the right gastric artery, and with the robot, it's feasible not to do it because the anastomosis is very easier with the robotic approach. We always do with my left hand or number one, the arm, as different of Dr. Sanchez Pernaute, from the right side of the patient. We do the section, and we have the duodenum. Of course, if you ligate your right gastric artery, you're going to have way more easier the anastomosis. Then we put inside our sutures. I always do two posterior with barbed suture and only one anterior. So we get our ileum and start the posterior way with the robot. This anastomosis is beautiful, very easier. We never do it with mechanical. I think it's very difficult, as Dr. Osorio says before. And we do the enterotomy, and they do the anatomy. It's a small bowel anastomosis. So then we do the first anterior layer. That's good, blood there in the duodenum. That's always, we always get happy with that. And we do the first layer, anterior, and then we do the second one, as we are going to see. The sleeve with the robot is not always easy. You got very thick levers, and I don't know. When we make only a sleeve, I think it's better with the laparoscopic approach. You don't need the robot. But in SADIs, you need to do it. And this is the, I'm sorry, we only do one anterior one. That is this one. And I think we can pass it. We always do the check or with the methylene blue, and that's it. So I think it's not the future, it's the present, and the integration of artificial intelligence and machine learning, they're going to help you a lot with intraoperative decision and their partial automation of surgical tasks right now. And with the increasing competition, we got so many robots today, so many new platforms, the cost that is a big issue are going to get lower and lower. Well, thank you very much.
Thank you. Thank you very much, Carlos. We have time for one question, just one question. Please.
Yeah, go on, bro. You can just shout from there, don't worry.
I would like to thank Dr. Ferigny for his nice presentation. Do you routinely use ICG in your operations? And when I last talked with Intuitive managers, they are now developing special units for measurement of the intestinal length.
Yes.
Because it varies from one surgeon to another.
Exactly.
And to make a standard range, they are developing a new unit. What do you think about this?
Yeah, the DB5, the new platform on Intuitive, is going to have the new software that is going to have the limb. You can have the limb lengths, and I think it's very, very useful. We do it with a TPAP, it's 5 centimeters, and well, when we have a revision or something, or a cholecystectomy at the patient, we can see it's quite good, our medicine. And with ICG, we never use it, we only use it for, if I have people at the OR to show them the gastrointestinal, or a very hard case that you don't see. I think it's good to an anatomical identification if it's a hard surgery, and for you can use it for the bile duct, the common bile duct, but you need to put it like 1 hour before you start the surgery. But I think if it's like rectal cancer or something, if you do ICG, you're going to change your anastomosis because it's not well fluorescence. I don't know. I think there's no very good and hard evidence right now about that. So we never use it. The duodenal cuff, maybe sometimes you can see it a little contour but it's always have a nice recuperation. I don't know. I don't change my anastomosis if you see it black, of course, but well.
I'm sorry again. I prefer to use ICG especially in revisional cases because when anatomy changes.
That's it for the arteries and all that stuff. That's perfect.
Okay, thank you very much. Our next speaker is Dr. Erik Stenberg from Sweden. Young patients, big questions. Thank you, Erik.
Okay, thank you. I will try to keep this short because I realize that you want coffee, all of you. That's important, of course. But I'm going to talk a little bit about the young patients and with a particular focus on a little bit on the procedures that we talk about today. So I have no conflicts of interest that should be of relevance for this particular talk. Now, while the incidence of obesity among children and among the adolescents seems to have reached a plateau, at least in the high-income countries, the prevalence remains quite high in most parts of the world. Now, these young patients, they will have even higher long impact of living with their obesity in terms of stigmatization, in terms of comorbidities from obesity, and ultimately with a shorter expected life expectancy. Now, metabolic bariatric surgery will offer a quite good weight loss among these young patients that seems to be just as good or even better when comparing to adults. And the strongest evidence is available for the Roux-en-Y gastric bypass, but there are observational studies suggesting that the one anastomosis gastric bypass is safe to perform, at least with short-term complications in the adolescents. And the results seem to be just as good as for the Roux-en-Y gastric bypass when it comes to weight loss. Now, the younger adults, and in particularly people who are in the adolescence, they are not really just younger and healthier versions of the adults that we otherwise treat. They are quite different in some aspects. It is true that from a somatic point of view, they are usually healthier than the adults that we treat. But they have lived for a long time of their lives with obesity, and they have been facing obesity when they were very young. So they and their families will have suffered from significant stigmatization through their lives. They often have a more advanced psychosocial burden when they present for surgery. And they also have different interests in surgery. What brings them to surgery often is quite different from adults. They are, for instance, more interested in the aesthetic point of view. At least the young adults are more interested in the aesthetic point of view from treating obesity. And studies have shown that as many as 70% will want to have surgery for excess skin, which is much higher than we would expect in the adults. Now, performing bariatric surgery in adolescents means that we will be performing surgery for many of these patients during puberty. And studies have shown that while this may be a concern, it seems that the sex hormones, they actually normalize and the expectancy of growth and the height that the patients will reach seems to be normal, even when performing bariatric surgery during puberty. But there will be challenges when it comes to bone health. The children will have a stronger bone health when they present for surgery, but metabolic bariatric surgery will influence the bone health negative, and there appears to be a higher risk to suffer from fractures in the future. And finally, the younger patients, the younger adults and the adolescents, they are more inclined to participate in risk behavior when it comes to sexual aspects, when it comes to alcohol and recreational drugs, and when it comes to behavior that will ultimately increase the risk of accidents or other unfortunate happenings. The younger adults, they are in many ways slightly similar to the adolescents. They have the best effects when it comes to weight loss after bariatric surgery, as suggested by this graph, which shows particularly good results for the males. But even though the weight loss influences the quality of life, the effects on quality of life, in particular the obesity-related quality of life, we see the opposite when we look at the effects of quality of life. On this graph shows the effects on obesity problems, and the higher you score, the higher problems you face. So if we look at the weight loss, we would expect the younger adults to have the best effect when it comes to obesity-related problems, but this is not the case. They actually improve less than the older patients who we operate. From a physical point of view, they do actually improve even better than the older patients. But if we look at the mental side of the health-related quality of life, our younger patients tend to do worse. They experience more problems related to their mental health. And this, just to make it a little bit more difficult, this graph is on the opposite to the obesity problem scale. So the higher you score, the better your quality of life. This also influences the most severe complications related to psychiatric health or mental health, which comes to self-harm and suicide, which is higher among the patients that we operate with bariatric surgery than you would expect if you compare to a population of similar age and of similar sex in the normal population. And if you look at the risk factors for self-harm and suicide, you will find that the stronger the procedure, the more malabsorptive, we shouldn't talk about, of course, malabsorption and restriction, but the more powerful your operation, the higher the risk for self-harm and suicide. And also, the younger the age of the patient, the higher the risk for self-harm and suicide. So this is something we need to consider when we treat younger patients. The other thing is related to the fact that these patients that we operate early on in life, they will live with their procedures for many, many years to come. At least 60 years they will live with the procedure. And then we need to address the long-term or the very long-term complications that may occur. And one of them is related to malnutrition, and in particularly malnutrition related to micronutrients. And this is a recent study looking at one of those as iron deficiency and anemia, which is more common among young adults compared to older ones. And the other thing is that it remains highly important that these patients are followed and that they take their supplements that they're supposed to take, and that they are highly compliant to our advices and what we suggest for them. But it turns out that one of the more important risk factors for not attending important follow-ups and not following the suggestions and the recommendations that we give is actually age. So patients of younger age tend to be lost to follow-up earlier on than older patients. And finally, I'm not going to say too much about this, but I have to say something about it related to the one anastomosis gastric bypass and to some extent to the SADIs. And that's related to the effects of reflux. Now, we heard about this study earlier on that from a clinical point of view and in clinical studies, the risk of bile acid reflux appears to be not that high. And in a meta-analysis reported about 4% risk of bile acid reflux. But that's from a clinical point of view. There are actually experimental studies suggesting otherwise. And this is a study from France, or actually two studies from France, showing that the one anastomosis, in that study, the one anastomosis gastric bypass was associated with a 4 times higher bile acid concentration in the esophagus and quite high incidences of histopathological changes in the esophagus, in the remnant stomach, and in the anastomosis. And as we know, these changes take 20 to 30 years to develop into cancer. So there really is a need to follow these patients thoroughly for a long time and also to conduct long-term studies addressing this issue. And then finally, related to gastroesophageal reflux, and this is again the study from France, the randomized clinical trial comparing the one anastomosis gastric bypass to the room Y gastric bypass, showing quite high incidence of symptomatic gastroesophageal reflux in the one anastomosis gastric bypass group. And finally, this is a small study, but an interesting study reporting the results when converting the sleeve gastrectomy to the one anastomosis gastric bypass, again with quite high incidence of histopathological changes in the esophagus and in the remnant stomach. So this again highlights the need to follow young patients operated, particularly with these procedures, that we need to follow them for a very long time, and we need to conduct long-term studies addressing the effects of long-term complications. So to summarize, the metabolic bariatric surgery in adolescents and among the younger adults is very efficient. It's safe in the short term, and it's very efficient when it comes to weight loss and when it comes to metabolic results. But the young patients, they often have a quite significant high psychosocial burden that we need to address, and we need to take, as a healthcare system, we need to take good responsibility and provide a good and close and individualized long-term support and follow-up for these patients. We need to take the responsibility for a long time if we operate in the adolescents and also among the young adults. Thank you.
Thank you very much, Eric. Any questions?
Yes.
Okay, I think we are getting one.
Would you even consider OAGB as a first procedure in an adolescent patient?
Well, coming from Sweden, I didn't say my biggest disclosure is actually that I perform more than 80% Roux-en-Y gastric bypass. I would not do that. I would do a Roux-en-Y gastric bypass because I think it has the strongest evidence when it comes to adolescents. The best studies are done for the Roux-en-Y gastric bypass, and we know the long-term results. So, but I am biased, obviously.
Well, I'm from Switzerland. It's also a very Roux-en-Y country, but my thought is the sleeve is not reversible. You told us young patients will have to live with the operation for a long time. The easiest of the two, Roux-en-Y or OAGB, to reverse is the OAGB. So is this a thought, maybe, in terms of future reversibility? You only have to reverse the stomach to the remnant stomach, and otherwise, the Roux-en-Y is also not that difficult, but it's just one thought, maybe.
You can reverse it, but I would say that the goal is not to reverse the procedure, but if we treat in adolescents and if we treat the young adults, they usually have a high burden of disease. So, and we know that the long-term results are good for the Roux-en-Y gastric bypass. We know that we prolong the life of these patients for a significant time, more than 9 years if they have diabetes. So I would consider the most effective and safe procedure, which is, to me, the Roux-en-Y gastric bypass in adolescents.
Thanks.
I think the problem with this patient, in our experience, there are 16 years, 15 years, with a very high BMI.
Yes.
And if you do a Roux-en-Y gastric bypass, maybe in 10, 15 years, weight regain, and you don't have any other issues. So we prefer always to do a sleeve, less aggressive, and maybe in 20 years, you can have a DS or a SADI procedure for the weight regain. Personal opinion.
Yeah, that highlights the complexity of the question. Thank you.
Thank you very much, and thank you, Eric. And now I have the pleasure of inviting Professor Gerhard Prager from Austria, our past president from Big IFSO, and he's going to talk, obviously, on a very interesting topic of the cancer concerns, because when it comes to this operation, there's always a debate about either malnutrition and cancer. So, Gerhard.
Thank you, Chetan. Thank you for the invitation. The field was already made. You see my disclosures, my case mix slide. I have to confess that I do OAGBs and SADIs. SADIs after I visited Andres and Antonio in 2015, and OAGB since 2010. And connecting to the former discussion, in 2011, I changed the way I do the Roux-en-Y with a long, narrow pouch and a 150 BP limb since 2011 and the 75 elementary limb. What are the concerns now? In the OAGB, clearly bile reflux, GERD, Barrett's, and upper GI cancer, the numbers in SADIs are increasing, but the data on reflux and Barrett's are scarce. This is, I think, already one of the conclusions. So why should we surgeons worry about bile reflux? Because there are some experimental and also clinical data that connect or link chronic bile reflux with adenocarcinoma, especially in the esophagus, but also in the stomach. And I will show you some of these data later. These are the pathophysiological mechanisms behind it. And of course, both procedures potentially increase the bile reflux mainly to the stomach, but also, and which might be more of a concern, to the esophagus. There are also some newer experimental data that could not find an increase in cancers of the esophagus and the stomach in rats. These are studies from Jean-Marc Chevalier's group, 16-week follow-up, quite fancy, even using PCR analysis and carcinogenic genes, and they could not see an increase. But one has to mention that the mucosa in the rat does not mimic the human mucosa. So you have a different distribution of mucosa in the rat compared to the humans. And another study from him with a 30-week follow-up that mirrors a 20-year follow-up in humans. But maybe I'm totally wrong. When you look in the older literature, and some of you are in the room, bile reflux doesn't seem to play a role at all, between 0.4 and 2%. So these are our own data from Vienna. In Austria, public healthcare system, very low threshold to undergo a second operation. Mean follow-up, and I think this is always very important when you mention data with revision or reasons for revision. Mean follow-up was approximately 6 years, and you see our rate of revision was 4.1%. The reason for marginal ulcer conversion or revision was less than 1% or approximately 1%, and these are old data, so in the beginning we had longer PP limbs, so we also had less than 1% malnutrition or protein malnutrition in our cohort. But we are not alone, you heard it already. Also in the maybe most important trial, the Omega trial, in the 5 years result, the conclusion was a concern about the high rate of gastroesophageal reflux. When we converted our patients, we saw in quite a number of patients a problem from the common channel to the abdominal wall. But I never dared just to take down that adhesion, because when you have an adhesion from the common channel to the abdominal wall and the patient lies flat in the bed in the night, and that's the typical complaints of the patient, doctor are drawn in bile, or suddenly a high volume reflux comes up. So you could potentially just take down that adhesion and look what happens. But we never dared, we converted all to Roux-en-Y and they all were fine afterwards. How do we diagnose bile reflux? Of course, number one, with gastroscopy. Number two, maybe with impedance pH testing. There are other very fancy things, and we have some experience, for instance, with MRI, with PrimoVist, which is a wonderful diagnostic tool. And the very old Bilitech is not available anymore, forget it. We used the last probes all over Europe. We performed an RCT, and we bought all existing Bilitech probes, so you can forget Bilitech measurement, but it doesn't take any advantage. So we tested also some OAGB patients, and you can see the number of refluxes. You can't see maybe I can show it like that. You can see that the number of refluxes before the operation was 52. After OAGB, it was 58. No significant increase. Some surgeons would claim you see a decrease in acid reflux. And it is true. Before the operation, acid exposure time 4%, which is actually in the normal range. After OAGB, acid exposure time 1%. Highly significant decrease in acid exposure, and the Demester score that depicts the acid reflux went down from 17.5. You see, in patients with clinical reflux, we don't go for OAGB, we go for Roux-en-Y. So the pre-op Demester score is almost in the normal range, but afterwards, a decrease. But this is only half the truth, because when we look at the non-acid refluxes, you see before the operation 24, after the operation 48. So a doubling of the non-acid refluxes. But has this a clinical consequence? The majority of these patients are asymptomatic. What is about bile reflux? After cholecystectomy, you see up to 58% in the stomach of bile. But does this have a clinical implication? When you scope patients with normal anatomy, you often see bile in the stomach. And when we look at the long data dating back with Billroth 2 resections and the fear of stump cancers, Helicobacter pylori was much more important maybe than bile reflux. And there are several studies showing that. And in the next slide, I'll show you a New England Journal of Medicine study that did exactly what was questioned by Eric. They looked for 25 years. They have a loop reconstruction, Billroth 2, 388 patients had surgery for ulcer and were followed up to 25 years. And you see the prevalence of gastric cancer was not higher than expected. And there are several other studies. I just summarized it for you. And when we look now in the literature, what are cancers there for Roux-en-Y and OAGB? You see 3 out of 8 cancers after OAGB was reported in the gastric tube, but 5 out of 8 were in the gastric remnant, whereas interestingly, in the Roux-en-Y, the opposite is true. So is it really the bile reflux or something else that contributes to cancer? I have no clear answer for that to you. But historically, when we look back, you might remember the Mason loop gastric bypass that was performed like now 50 years ago in the US, approximately 8,000 patients. There is no report of a tremendous increase of cancers. And the same might to be true after Billroth 2 and now OAGB from 1997 on. We still don't see an alarming signal of increased cancer. So my first conclusion for the biliary reflux, bile reflux is common after cholecystectomy without clinical relevance. There are other factors like Helicobacter pylori that might be much more important. We see no cancer signal until now for Billroth 2 OAGB Mason loop gastric bypass. Some animal models show an increase, others not. I showed you a little bit biased, and due to the sake of time, those that did not show an increase. And I'm convinced that much more important is the breakdown of the anti-reflux barrier, and I just want to mention intrathoracic migration after sleeve, after OAGB. We found in our studies after sleeve a 40% de novo hiatal hernia, we called it at that time when we published it. But what is it? They didn't have hernia before. It is intrathoracic migration of the sleeve part, and that might contribute also here. So in the SADI-S, we have much more limited data even, so there is only one study that compared bile reflux with OAGB, and it's very logical. The pylorus is protecting a lot of bile going to the gastric sleeve and maybe even further up to the esophagus. Concerning Barrett's, you see that after OAGB, we also have only few data showing Barrett's actually in a range you would expect between 4 and 10%. The cancers are already mentioned to you. So to break it down, until now, we have no data to claim that after OAGB there is a higher increase in cancer compared to other operations. Nevertheless, I think we should monitor these patients, we should select them properly, and the bile reflux and Barrett can develop. Often they stay asymptomatically, and the SADI-S data overall are extremely limited. I think what Eric mentioned before, endoscopic follow-up should be mandatory in these patients, maybe first time after 5 years, and then in asymptomatic patients every 5 years should be sufficient. Except the patient has Barrett metaplasia, then you might do the intervals a little bit more often, down to 3 years according to the recommendations of the gastroenterological associations. Thank you very much.
Thank you very much, Gerhard, for this excellent talk. Do you think now, probably after so many years and decades of experience, we should put this debate at rest that OAGB or SADI or all do not actually increase the rate of cancer in either the anastomosis or the gastric pouch or the OG junction?
I would name it a little bit different. Until now, we have no evidence that it increases it. Maybe in 15 years, it could slightly change. I personally don't believe that we see a big peak of cancer. But this is not evidence, this is eminence. Until now, the evidence is that there is no higher increase. Mario.
Thank you so much, Gerhard. Great talk. You just hit the point. So I just wanted to stress one concept, and you already quoted it. Why do we fear, or I started more than 15 years ago with the OAGB, why we do have to fear an eventual gastric cancer following OAGB? For the reason that it resembles in some way the old Billroth 2. That was, under a technical point of view, a totally different surgery, okay? But we don't have to forget one thing. The vast majority of gastric stump cancers that have been found starting from mid-70s and up to early 90s were linked to people who had surgery, gastric surgery for benign ulcers in the late 40s, 50s, 60s. At the time, the Helicobacter pylori was totally unknown. You know? And it is has been defined as a clear carcinogenetic agent. So the H. pylori has been discovered in 1983, and after that, the H2 antagonists, the PPIs, have decreased very, very much the incidence of the ulcers and the following. So this is the simple reason, because we do not find any cancer following OAGB or SADIs or whatever. So this is my comment. Thank you.
I tried to point it out with the Helicobacter pylori. But I give you another piece of thought. Why do we believe that the length of the gastric pouch between 10, 15 centimeters plays such a difference in bile reflux? Because when we look for the alimentary limb in a Roux-en-Y reconstruction, and we make the limb of the small bowel that has a high degree of peristalsis, a very nice degree, and we make it 20 centimeters, I think all people in the room would consider it too short, right? So with 20 centimeters of small bowel, nice peristalsis, you can have bile reflux. So why do we believe that 2 or 3 centimeters more of stomach length have such a big influence on bile reflux after OAGB? I think much more important is an intact gastroesophageal reflux barrier. The peristalsis of the stomach is much less than of the small bowel. It's only every 20 seconds approximately you have contraction waves, and it's a totally different physiology.
Thank you. And I think we obviously need to appreciate that obesity itself is a cancer risk. So not doing anything gives an increased risk anyway. And even in patients with obesity, or well, even normal population, the rate of Barrett's is 5 to 15%.
Yeah.
Whereas you quoted that in all bariatric surgeries, it's less.
For the sake of time, I didn't mention that. When you look for the literature and the impact of metabolic surgery on cancer prevalence, you see a reduction in esophageal and gastric cancers after Roux-en-Y. In some studies, you don't see it after sleeve. For OAGB, we have no data.
Thank you.